when we think about this topic, we think in biomechanics, and you Google, you go into PubMed, and you try to find papers about this topic, and you find, in my opinion, three groups of papers: biomechanic papers about technique and videos, as Ivan just showing us very well, and the results. I mean, what happened when we put in practice the biomechanics and technique, and about the results, it's what I'm going to talk in this talk. I have three questions for answer. If this technique is safe and effective, what is the clinical and radiological long-term results, and what happened if we compare the iliac crest against the lateral jet? Okay, it's safe and effective. Actually, Ivan just published this paper. I'm going to show paper from the last 3 years. It's a short follow-up, 1.4 years of follow-up, 13 patients. And what they found, the authors showing us, is that all the patient improve in score, the movement improve, the instability improve. They didn't find any dislocation or apprehension, no interperative complication, no neurovascular injuries, no infection, no major bleeding, and just have one partial graft non-union. I mean, looks like it's effective and safe. But what happened with the resorption or remodeling of the graft? Look, 10 of 12 patients have less than 50% of the resorption of the graft, and one have more than 50% of the resorption. But it's a lot of patients with the remodeling of the graft, but without a clinical implication because the patient remains stable in this paper. This is another paper, 5-year follow-up, 24 patients with a glenoid defect from 22%. The technique is similar that we use right now, and all the patient improved in all the score, but the internal rotation was the only movement that was decreased if we compare it with the other shoulder, and 13% show excessive graft absorption. I mean, the absorption is a problem, and look, here appear another problem, and is the other osteoarthritis. 50% of the patient increase the grade of the osteoarthritis in the Kellgren-Lawrence classification. I mean, it's absorption, remodeling, and arthrosis. This is another paper, 15 patient, 1-year follow-up. None of those patients show subluxation or redislocation. 11% was a complication, but not a big deal. It was just hematoma and reduced sensibility over the iliac crest. And none of those patients show resorption, but those patients, 35% show mild osteoarthritis. I mean, this is a other patient, other study, 22 patients, and compare allograft with autograft. And looks like the logical say that it's better if we use autograft. In the Oxford score, show that it's better the autograft than allograft, and the resorption is more resorption in the allograft group than in the autograft group, and the no-union rate was higher in the allograft group. Okay, this is, looks like it's effective, the surgery, and it's safe, but could increase the osteoarthritis. And what about the clinical and radiological long-term results about this technique? This is a paper with a huge follow-up, 18 years, 34 patients at the end of the follow-up with the J-shaped graft technique. Use it, and looks like all the patients improve in the movement, improve in strength, and it's almost similar than the contralateral side. They have just one redislocation. 77% of the patient has apprehension and relocation test negative, and just 5 patients has a hypoesthesia at the iliac crest. But almost all the patient was satisfied, and no correlation between preparative factor and clinical outcome scores. It looks like it's is still effective and safe. But looks here, looks this graphic. The normal joint space was just was the 77% of the patient, and narrowing in this 23%. Look like a 25 patient has osteophytes, and the CAA score was 0.9, and if we compare with the contralateral side was 0.4. I mean, look like this technique, or maybe the trauma in the shoulder increase the probability to have osteoarthritis. Look, in the affected side, they find that no sign of instability arthropathy in the 26%, and in the contralateral side was 69%. And it looks like a huge difference between the affected side and the contralateral side in terms of the osteoarthritis. This is another paper with 5 years of follow-up, just 14 patients with autograft, and they show just one dislocation, improve in the scores, improve in the movement. But look, this is what we were talking in the discussion before, the graft remodeling, and try to adopt the pure shape of the glenoid with the follow-up. This is another paper with 3 years of follow-up with autograft, with fixation with bottoms. And again, looks like all the score improve in movement, improve in strength, improve in the recurrence of dislocation. I mean, they find that there's no recurrence in their patient, no subjective shoulder instability, no major complication, and the postoperative shoulder range of motion was almost equal to the contralateral side. I mean, at this point, this technique looks fine, effective, it's safe, and the result, and in the long term, is a good result. And what happened if we compare this technique with the lateral jet? Dr. Wong just told us about this study. Was 60 patients, was randomized, and look, all the score improved in the same way. I mean, all the were no different between the lateral jet or the iliac crest, except in the internal rotation was the only point that the lateral jet was inferior than the iliac crest. And look, the complication was a heterogenic complication. In the iliac crest, the problem was more in the donor side, and the lateral jet was more that scapular dyskinesia. And it's no different in pain and satisfaction. I mean, at the end, our question is, this technique is effective and is safe, can increase arthropathy. That is a theory, because actually I'm not sure it's about the technique or about the disease itself, and is effective as lateral jet. Thank you very much.